Okay. Mr. Mohammed, you can start now.
Thank you. Hello, everybody. Thanks for joining us. This is Amin Mohammadi, and we are with you with the fourth lecture session of Information Management Systems in Nursing, conducted by Tehran University of Medical Sciences, directed by Dr. Khatara Seilani from Department of Intensive Care Nursing and Nursing Management, and moderated by Dr. Asiya Darvish from Department of Medical Surgical Nursing from School of Nursing Midwifery at Tehran University of Medical Sciences. Previously, a short course entitled as Fundamentals of Nursing Informatics was represented by our team. And in the current course entitled Information Management Systems in Nursing, we have had Artificial Intelligence Nursing and Leadership Considerations Re-envisioned Informatics Competencies for all nurses in first and second sessions by Dr. Marissa L. Wilson, and in third session, we have had nurses' role in technology selection, design, and implementation, presented by Dr. Tanya Azadi. And in this session, we have clinical information systems in nursing, which is going to be presented by Dr. Melody Rose, who is an adjunct professor at Franklin University. She holds DNP of Nursing Informatics, MSN of Nursing Informatics, RN license, and is a certified professional of healthcare information systems, which is CIPA-HIMSS, through HIMSS North America. Dr. Rose serves in clinical informatics at Ascension Healthcare. Previous roles have included Director of Meditech, Clinical Informatics at LifePoint Hospitals, Clinical Informatics at Healthcare Corporation of America, ACA, and Nursing Supervisor at ACA. Dr. Rose has worked with Meditech, McKesson, now as Allscripts, and Cerner EHR Systems. Some of her skills include enterprise-wide clinical information systems, HIPAA, which is Health Insurance Portability and Accountability Act, and Security and Auditing, Healthcare Information Technology, Leadership, Healthcare Consulting, EMR, Research, Hospitals and Hospital Systems, Healthcare Management, Ambulatory, CPOE, Nursing, EHR Technology, HL7, Marketing, Higher Education. Hello, Dr. Rose. How are you? You're at your service.
Hello. Thank you for that introduction. I'm very thrilled to be here. Are we ready to start, or are we going to talk a little bit?
Yes, but before starting this session, we have to launch the poll. We have a pre-test that consists of some questions. I launched the poll and I kindly ask our participants to answer this poll.
Okay. Well, let's get started. And I just want to greet everybody and hope that we have new people and greet those old friends that I met. It was a thrill to see faces on the screen that I met from the last lecture I did. And I want to thank everybody and tell you how excited I am to be here. And thank you for inviting me back. Let me introduce myself. My name is Melody Rose. I am a registered nurse, and I am a doctor of nursing practice. So let me start by telling you a little background about me. I started my registered nursing career with a 2-year degree, an associate's degree, and I worked for 25 years before I considered going back to school. There were many things that happened in that time, but one of the main things that happened was the birth of nursing informatics. So every time that I looked at going back to school in that 25 years, I didn't find what I wanted, and that was part of the delay in going back to school. I knew that I didn't want to be in administration, and I was pretty sure that I didn't want to go into CRNA, anesthesiology, and I knew I didn't want to go into education. Nurse practitioner was not around at the time, and there was no reason that I thought of that I could go back to school. There just wasn't anything I was interested in. But early in my career, I was selected for a computer assignment, and I loved that. I kept going back into computers, but nurses didn't work on computers. I found out about the ANA subspecialty for nursing informatics in 1994, and at that time I was working in computers again. And then I found out that the ANCC offered a certification for nursing informatics, but the minimum education level was a bachelor's level. And here I go back to that 2-year degree I had, an associate's degree, and I didn't meet the qualifications. I didn't have that bachelor's degree. So at that moment, I set a goal. But life happened, and I wasn't able to go back to school until the online platform for nurses became available. I eventually graduated in 2011 with a master's degree, specialty in nursing informatics, and then in 2014 with a doctorate. Now, I still don't have that bachelor's degree. I bridged from an associate's degree to a master's degree. So what have I done as a nurse? Clinically, I've worked in medical telemetry units and emergency departments. I've also spent a lot of time as a nursing supervisor, overseeing the entire hospital and being the administrator on call or on site. Currently, I work for a major healthcare corporation in a clinical informatics role. It's a hands-on level, but I have a few goals that I'm achieving with this position. Up until a year ago, about the time COVID started, I still worked clinically as a nursing supervisor. For most of my clinical informatics career, I have worked a PRN clinical role, a second job. I knew it was important to keep that clinical hand in place. I left the nursing supervisor position because of our clinical informatics hours as they escalated to keep up with COVID demands. In informatics, I've built many different types of systems, from standalone to enterprise-wide. Major systems that I know are Meditech, Cerner, McKesson, which is now known as Allscripts. I've built, upgraded, deinstalled, redesigned, reviewed for compliance, and many other things, but those are the major ways I've used my informatics background. Somewhere in there, I've done education for many of these systems. I've worked at the facility level, the market level, which are several facilities working together, and the corporate director level, which are markets of facilities working together across the country. I've also taught at the university level in bachelor's, master's, and doctorate programs. I've taught nursing care, nursing informatics, and health administration programs. And I've also written coursework for nursing master's programs. Publishing has not been a top priority, but I have published, and I plan to do more of this in the future. Through all of this, I've had life events that have happened, good and bad, and I would encourage you to keep your eyes focused on what your dreams are and work to get those dreams. Sometimes your steps seem small, but keep taking those steps. You'll get to your goals. So now you know a little bit about me. Let's move on to the clinical informatics systems in nursing. So our objectives today, we're going to identify the use of DIKW in nursing informatics. We'll recognize the financial push incentivization had on electronic health records, identify 8 principles of information governance, identify shared documentation data points, identify data-driven operations, recognize the emergence of remote systems in healthcare, and recognize the increasing roles for nursing informatics. Now, when we talk about clinical information systems and nursing, our first thoughts go toward the acute care setting, the hospitals. The fact is, informatics are used across almost every aspect of life. These different levels of informatics contribute to large collections of data and databases. So here's an example. When I go to the airport, or even the last time I had a blood draw in a clinic, I scanned the back of my driver's license, and my personal information populated the screen with different demographic information, my name, my age, my gender, address, things like that. There is a national and probably an international shared database of information on most people. In the United States, the Health Insurance Portability and Accountability Act, and you know this is HIPAA, passed in 1996. The act initially addressed the portability of insurance, but also was the beginning of health information privacy rules. There have been many upgrades to HIPAA as healthcare technology has evolved, but HIPAA can be credited as the beginning point to electronic privacy for healthcare. What HIPAA means is that the average person can expect that their personal or private health information, and you'll see that abbreviated as PHI, that will mean personal health information or private health information. Those terms seem to be used interchangeably, but PHI will not be shared without specific consent by any healthcare provider. When a patient checks in, there's a lot of papers to sign, and many of those papers are concerning HIPAA consent laws. PHI can be shared with your eligible provider, your designated insurance company, and appropriate billing companies. These three areas are provided for. Other areas of your data can be shared with other instances where no personal information is included. This is called washed or de-identified data. An example of this would be all of the COVID statistics that are provided daily. So if you've had COVID-19, you're probably included as a number only, remember, washed data, in statistics. If you've taken a COVID-19 vaccine, your washed data is included in a statistic. There is a difference between sharing PHI or having your PHI shared and being part of a statistical database that is analyzed as de-identified or washed data. Now, in the United States, if you really, really don't want to be part of any data and analysis, you can opt out. You can sign a specific statement that says, no, I don't want to participate in any type of data collection, regardless of whether it's identified or de-identified. Even with that, there's still ways to collect similar data. In the case of COVID-19 vaccine, when 100 doses of vaccine are dispensed, the recipient is accountable for every dose. If you refuse or sign a waiver, the recipient will report back that 99 doses were dispensed and one was marked as disclosed. Since that one was not labeled as lost, dropped, broken, spoiled, or any other form, the non-disclosed is an unspoken signal for don't count me in statistics. So one way the statistical analysis compensates for this type of bias is to change the total doses to 99. So even though you opt out, in a way, you still have an influence in statistics. So data, knowledge, information, and wisdom is a nursing informatics model developed during the time frame that informatics was being integrated into nursing. The conception point was Blum's idea of data, information, and knowledge in the mid-1980s, followed by the inclusion of wisdom to make the data, information, knowledge, wisdom, the DIKW model by Nelson in the early 2000s. Let's talk about the ability of this model to develop and evolve in this time frame. In the 80s, technology was evolving and simply started to move into healthcare. First systems that moved into the healthcare were registration systems. We really did not collect much more information other than who you were, where you lived, and how we could get a bill to you. But at this time, systems were being developed and slowly came online. These systems came up one at a time and worked independent of each other. Many times the independent systems were built by different companies or vendors. In the United States, free enterprise is encouraged, so it's not unusual for a vendor to make their programs difficult to work with other programs or to make them proprietary. Another phenomenon in this time frame is the doctor with the special knack of informatics that decided to get into the business of informatics and develop software. This had advantages, but also drawbacks. Clinical input into research, design, and development is always welcome, but the business aspect of selling a product to the place you work for has bad business and legal implications that make situations difficult. Couple this with vendors that had begun developing individual systems that suddenly became integrated or talked to each other, and began offering enterprise-wide systems. So a common scenario that occurred, especially when smaller hospitals were being purchased by hospital corporations, was that a corporation would come in and assess the current systems and then tell the hospital. And this happened both with newly acquired hospitals and existing hospitals. It didn't seem to matter, but the corporation would come in, look at the systems and say, all of the systems need to come up into line with the corporate way. So get rid of Dr. Smith's ER system and install the corporate model. Now this message would go out to the CEO, and the CEO would go talk to Dr. Smith, who also happened to be the ED director of medicine and possibly this year's elected president of medical exec committee. And he had to tell him the news. Hey, Dr. Smith, we can no longer use your ED software in the hospital by corporate mandate. Well, Dr. Smith might just kind of get angry and say, dear CEO, do you know how much money I've invested in this software? My company did all the research and development without the support of this hospital, yet the hospital is receiving all of the benefits of that research and development. So Dr. Smith then tells the CEO that as long as he works for this hospital, he's not willing to accept any other software other than Smith's fabulous ER system, and promptly walks away. Now the CEO is faced with a dilemma. He can be fired by the corporation for not following the orders or he can lose his director of ED services, who also staffs in the ED and is the president of his med exec committee. Now I've seen this exact scenario. I've seen CEOs fired over this, and I've seen ED docs walk out. I've also seen ED docs that very graciously deinstall their product and allow the new system in. But that was the past. And fortunately, these battles were overshadowed and eventually extinguished by incentivized mandates put in place to help the electronic health record become a workable model. As much as we, informatics and clinicians, struggled to get the electronic health record in place and make it into a workable model, it did not happen until we were able to bring the executive component into the picture. The missing link for this was adding a financial implication, a federal mandate that tied a money trail to development of a successful EHR. In 1995, I worked for one of the major healthcare corporations in the United States. I had gone from staff nurse to an informatics nurse, and this was my second major deployment as an informatics nurse, and I helped build, test, train, implement, and upgrade the system that is still in place in that healthcare corporation. Now that corporation has purchased other hospitals that use other EHRs, and they have now adopted the notion of a healthcare data repository for reporting and interoperability rather than forcing new hospitals using other EHRs to work together or moving those hospitals to one EHR. And this is a concept that needs to be explored. We can talk about that more in a different lecture. In 2009, the American Recovery and Reinvestment Act was passed and followed by the Health Information Technology for Economic and Clinical Health, and thank goodness that was abbreviated to HITECH Act, which helped lay the groundwork for incentivizing the path of a working EHR. Now, during the previous 14 years of working with what some would argue the country's largest healthcare corporation and making very slow progress towards a functional and integrated EHR, this became a welcome stepping stone. These two acts brought in the financial and executive stakeholders' full-fledged buy-in to make the soon-to-come criteria, the stages of meaningful use, achievable. So the stages of meaningful use were introduced in 2011, stage 1, which was data capture and sharing, stage 2 in 2013, advanced clinical processes, and then in 2018, stage 3, improved outcomes. So when stage 1, meaningful use, was announced, the incentives were designed over a 3-year period. For facilities and eligible providers that met criteria early in year 1, they would receive 100% of the incentives. In year 2, they would receive 75%, and in year 3, they would receive 50% of the incentives, and this was considered full reimbursement. This was a stair-step approach. For facilities and eligible providers that were a little bit slower, maybe starting in year 2, they would receive the 75% incentive, and then year 3, 50% incentive. And then the slowest group, the laggard group that met criteria in year 3, only received the 50% incentives. But by the time year 4 started, and remember, by the time year 4 came around, meaningful use stage 2 was already in play. The incentives went away. And what came into play was lack of payment with Medicare payment. Medicare payment was reduced to penalization. So any kind of a Medicare payment was reduced or penalized. And then the next year, year 5, the penalty got bigger and so on. So the first 3 years, there was reimbursements on a stair-step reduction, $175.50. Year 4 was a reduction in payment that got bigger as the years go up. Now, you might think that simply not getting full reimbursement on Medicare and Medicaid patients is a small thing, but it's not. Technically, the federal government cannot mandate payment for independent insurance companies like Blue Cross Blue Shield, Aetna, United Healthcare, companies like these, but these insurance companies look at Medicare and Medicaid for payment schedules. If Medicare and Medicaid are not paying at a certain rate, they will duplicate that same rate. So by default, the federal government is setting reimbursement for the insurance companies. Executive and financial people saw the implications of this quickly and got on board with informatics. Where once there was very little or no oversight, now there was extreme interest and involvement on the facility side. The side effect from this was an interest in finding and keeping people to update systems and keeping systems current. So here's a little bit of an example, or maybe a history level or lesson. In 1995, after that initial enterprise-wide system implementation that I worked on, I was told that my position as an informatics nurse was not important. My value to the hospital was less because I did not give clinical care, and therefore I was not eligible for a raise. These words came to me from the chief financial officer. Multiple years later, I ran into this CFO, and he apologized for those words. He recognized how nearsighted he had been at that moment. Today, there are entire departments that support informatics and clinical informatics. We went from a famine to a feast. Some would say that we have been efficiently gathering great data since 2011, the beginning of meaningful use. We need to manage that data. When we talk about data management, there are many different perspectives. I think you have already had several different speakers on this topic, so I'm just going to touch on a quick overview. A model of principles recognized by the American Health Information Management Association, AHIMA, so that I know we are all starting from the same place for the next few points I want to talk about. There are 8 principles identified and accepted by AHIMA that healthcare should be working towards, and these are accountability. Accountability is an information governance program and delegation of responsibility for the program that should be in place. This includes records and information for patient care. The organization has the responsibility to create and enforce policies and procedures to provide for accountability. Integrity. Information generated and or managed through information governance processes and has a reasonable and suitable guarantee of authenticity and reliability. Protection. Information generated and or managed through information governance processes will ensure a reasonable level of protection for privacy and confidentiality. Compliance. The information governance program will comply with any applicable laws, compliant with governing authorities, and within defined policies. Availability. The facility organization will maintain records and information in a format that ensures timely, efficient, and accurate retrieval of needed information. And pause here with me for a minute and think about your own personal computer. I have my beloved laptop that is a Windows XP platform that's stored in my closet because I can't use it anymore. There's not a whole lot of support for Windows XP. And today we're using Windows 10. Now consider the principle of availability from 2011 to now. That is a huge ask to be able to keep information available from platforms from 10 and 20 years ago. So that's big. Retention. The facility or organization will maintain records and information for an appropriate amount of time. This is for legal, regulatory, fiscal, operation, and historical requirements. Now, my personal EHR would have started in 1995, way back with that initial EHR that I worked on for the major healthcare corporation when it went live. That was 26 years ago. Those records are still available today. A paper record would not be available. They would have gone to storage after 3 years and they would have been shredded after 7 years. So the electronic health record has huge benefits. Disposition. Records that are no longer required, paper records, signature forms, anything that's not stored electronically, downtime forms. Usually 7 years is a storage limit. 2 years at the facility and site and 5 years off-site are disposed of properly. Shredding is usually follows a policy. And by the way, most paper records, like anything that has a signature, they're scanned into the EHR at the end of the patient encounter anyway. So shredding a document should not be an issue. And then the last principle is transparency. Facility and or organization has business practices that should be public and available to anyone that inquires. So let's talk about data threats for a minute. I'm simply going to touch on this topic because I believe you've heard from other people on this topic, but I might have just a little bit of a different take on it. Data threats can come from very simple sources to very complicated sources. We all have to be cognizant of protected data. So here's an example. If you walk into a nurse's station and you see papers laying face up with patient information exposed, pick them up and turn them over. This is simple. I see doctors that will walk by a nurse's station and lay a chart, and yes, we still have paper charts. They're much smaller and usually contain documents that either require signatures or have transferred documents that are not part of the EHR yet. That doctors will lay them on the counter rather than securing them in the appropriate secure location. Anyone can walk by and pick up papers or a chart from the counter and walk off. People can read upside down from a distance of 5 feet if they're standing looking over a counter onto a desk surface. I've had patients walk out to the nurse's station and pick up papers off the counter and take them back to the rooms. The papers did not belong to them. I had one patient that took someone else's discharge paperwork home. This created a HIPAA violation for the hospital that had to be reported. Simple or complex, securing data is everyone's responsibility. Securing devices, lock them, put them on a big cart, makes them easier to roll around anyway, anchor them to a wall. Even with these precautions, people will still be able to get out the door with them if they really want to, but make the effort to secure the devices. Password protect devices outside of the physical security and then secure at the user level. If possible, place devices behind a locked door. So 3 to 4 levels of security. Behind a locked door, a physical lock on the device, password protect the device, and then specific user password. What if a virus or something like a virus, a worm, a Trojan, there's all kinds of names. I can't even keep up with the names. What if something like that gets introduced into the system? Shut down the device, disconnect it from the network, and call IT services. And by the way, unplugging it from the electricity is not disconnecting it from the network. You have to disconnect the network cable. Chances are you're not the only one that this has happened to, so be patient when you're calling IT. Wait for instructions. We hope this does not happen. I suspect you all have gotten emails from your IT department about phishing scams, so pay attention to these emails. Don't open the type of email that looks like it could be a phishing scam. Don't click on the links. Pay attention. In my day job, I'm constantly receiving these types of educational emails. However, half of my work comes to me from outside emails, so there are some times that I have to take a chance and open something or ignore it. I'm getting better at ignoring them. I figure if it comes back to me 3 times, it might be important. When bad things happen, ransomware can sneak in. You may have heard a few weeks ago, one of the oil refineries in the United States was hit by a ransomware attack that shut down the Continental Pipeline. Now, the pipeline supplies petroleum products to my area of the country, so I was directly impacted. I thought I might be back working remotely again for a few days just because I couldn't get fuel for my car. These types of attacks are not aimed solely at healthcare. They're aimed at anything that the attacking force can make money from. This is a form of free enterprise that hurts everyone. This also becomes a good news, bad news scenario when we, the IT community, finds a way to stop or circumvent hostage situations with ransomware. Then the attackers, the hackers, find new ways to attack. So there will always be opportunities in the area of data threats and data protection. Now, I want to take a small amount of time and talk about security from a couple of different angles. Part of HIPAA is keeping the patient's health information safe and secure. When computers first came online, we really did not think about securing information. A patient's paper record was in the chart wheel. Any doctor or nurse, technician, basically anyone that looked the part could walk onto the floor, pick up a chart, and look through it. Nurses did not often challenge someone that looked the part. We might gather in a corner and ask each other, hey, who's the doc over there? But by the time we figured out that no one knew the doc, he would be gone and the information was viewed. When computers came in, there was no security to stop people from looking at electronic records. So we went from a group of nurses whispering, who is that, to someone that had a password or was smart enough to figure out a password and look at anything they wanted to, and no way to audit this. My first experience with this was finding out that I was pregnant by looking up my own labs online. Now, I don't mind sharing this story because it has a happy ending. I had been monitored by my doctor. I was having weekly blood draws. We were watching my HCG levels to make sure they were staying down. If they went up, it meant I either had cancer or I was pregnant. I had had a blood draw early in the day, and then I went to work an evening shift. I was a nursing supervisor, and I looked at my own lab results that evening and saw that my HCG level went up. I had an extremely anxious next 16 hours until I could get to my doctor. The good news was I was pregnant. About 3 weeks later, while at work, and again, I'm the nursing supervisor, I got a phone call from a nurse who had also been looking at lab results, but she was not looking at her own lab results. She told me that her coworker, who was not at work that night, had called in sick. When this nurse looked at the coworker's lab results, she saw that the coworker probably had a tubal pregnancy and needed to come in right away. No one had been able to find the coworker. It was at that moment that I realized how invasive people could be by looking at private information. Now, this was in 1990, 6 years before HIPAA was passed. And remember, when HIPAA originally came into effect, it was enforced for health insurance portability rather than accountability. Accountability enforcement took several more years. Now, I'm going to segue up to 1995 and tell you another story. I was installing that first enterprise-wide system that included all elements of the electronic health record. And this was done with a big bang method. We did one hospital at a time. We waited 4 to 6 weeks to troubleshoot issues and then brought the next hospital live with a big bang, and we brought up a market of 8 hospitals. There were so many lessons learned with this project, but what I'm talking about specifically is security. This implementation was in Nashville, Tennessee. Another name for Nashville is Music City. Nashville is known for famous singers and artists because of the recording industry. Where there are famous people, there are people looking to find information to publish about famous people. Right away, when famous people were admitted, employees of the hospitals were offered money to disclose information about the health of famous people. This could be done from this could be from anything from new babies to major surgeries to emergency room visits. It didn't matter. Information could be viewed from any of the 8 hospitals about famous people. Quickly, we learned how to audit patient records to see who was looking at them and if the person looking was supposed to be looking. The healthcare corporation I worked for implemented a policy of a minimum number of random audits every month looking for irregular accesses. And remember, this is still before HIPAA. I learned how to audit records and begin seeing patterns of activity. Once employees realized they were potentially being audited, the irregular accesses became much less. One interesting find was that doctors were making many more accesses than they needed to be. When asked about the accesses, many times they would say, well, that used to be my patient, so I wanted to see how they were doing, and I also wanted to know why they changed doctors. There were also malicious accesses, soon-to-be divorced husbands and wives that were looking at each other's health records, employees that were peeking at neighbors that happened to be admitted. One telltale sign of an inappropriate access is a person that is on the computer but in an unusual location. So if the person usually works on the 2nd floor and then has one access from the 5th floor, this is an indicator they don't want to be seen. When auditing, reports are randomly run on patients. All the accesses are viewed for people that are supposed to be looking at the chart. The auditor is challenged with recognizing staff by the way they sign in and the device they are signed on with. If the auditor finds staff that has an unusual access, then the auditor runs a report on the staff for habits and patterns. Another type of audit is when a patient requests an audit based on suspicion. I think my neighbor looked at my chart, or my ex-husband has information about my last hospitalization that he should not have. The patient will not be given the results of the audit. Only that information is the property of the facility, but the patient is guaranteed that there will be a follow-up. Now, that information can be discovered through a legal proceeding. The patient can call back and ask if the audit is complete, and that information will be disclosed, just not the results. So let's move on to data documentation. It's administrative data is data that is documented from usually the very first point of contact. And this means before the patient has ever sees a nurse or a provider. When you as a patient make first contact with a facility, your information, usually demographic information, name, address, insurance, next of kin, things like this, is collected by a registrar. You might also be asked if you have a living will or power of attorney, someone that will make healthcare decisions for you if you cannot. If you have these documents, they will be scanned into the system and become part of your EHR. If not, the healthcare power of attorney will be asked over and over. So several other questions are asked at this time and have had significant changes over the last few years. At least they have in the United States. So I'm going to make a point here, but bear with me. Gender. Gender, this used to be either male or female. Then we added declines to answer because we figured, the patient has a right to decline to answer this. Now we ask 2 questions, gender and gender identifies 2. Plus we still offer the declines to answer. So now there's 3 responses. How about race? This used to be a question that seemed simple, but now if you Google how many races are there, the answer comes back with multiple responses. I've seen 3, 5, 6, and 7. So now I tend not to place importance on this question because does it matter? Looking at genetic databases such as 23andMe or Ancestry.com, it seems that races have intermingled for many generations. So looking for one race of a person might be the impossible question to answer. Do you really need to know what race the generations before you were? I thought I did by the stories I was told, but I did a 23andMe DNA testing and found surprising results. How about ethnicity? Ethnicity also seems to be intermingled with race, and what might be more important to me anyway in the care of my patient is culture. Personally, I have found that culture is more of a key element when caring for a patient, and culture seems to have less importance placed on it than race, gender, and ethnicity. So my point with all of these words and data collection points are, number one, the beginning point prior to the nurse and provider. Number two, the amount of data has changed significantly over recent years. And number three, we need to examine exactly what is important to take care of the patient. Some of the information that is collected is simply to feed databases. I don't mind this. It's good information. It just does not always serve me for my patient care goals. Also, notoriously, questions have been given to nurses to ask and collect answers for that have nothing to do with the immediate care of the patient. Beware of this. Nurses are not an interview system for random data. The beauty of working within an enterprise-wide system is the ability to pull information to and from one place to another place. When a patient is registered, the demographic information automatically pulls through to the next module. So patient name, date of birth, patient identification numbers will follow. This is great news. This is one of the perks of an enterprise-wide system. One important example of this is allergies. We should only have to enter allergies once, right? Wrong. We always address allergies at every point because patients forget. So the nurse will ask allergies the first time, and the patient may say, I have no allergies, and this is what gets reported. The next point of contact might be when the patient is going for a radiology procedure that's going to use contrast, and the rad tech says, I see you have no allergies. Have you ever had a reaction when you eat shellfish? And the patient replies, well, now that you say that, yes, I have. And the rad tech enters shellfish as an allergy and notifies the radiologist before giving contrast. So instead of repeating the question, the next encounter repeats what is recorded with a subtle question. Why do we pull data from place to place? Well, because it makes our job easier, but we have to validate at times that the data is still correct. First, if there is a place that does not seem to be pulling data, but you think it should be, make a query into this. Ask the clinical informaticist about this. Next, instead of asking the patient, repeat the information recorded to the patient and ask them to validate the information. Plus, answers do change. Many times, there is a setting in the background that gets overlooked. Sometimes the setting has been turned off on purpose. There might be a reason for this. Occasionally, something simply gets missed. If there is a simple question that is always asked and you think the answer should be pulled forward from previous assessments and it does not, ask about it. It simply might be something that was overlooked. What about pulling data from encounter to encounter? Are there instances that we would want to pull information from encounter to encounter? Yes. What about code status? Have you ever resuscitated someone that was a no code? This happened to my grandfather. He was very angry. He had made his peace with death. His quality of life was not what he wanted, what he was used to. He was right with his spiritual beliefs. He was in the hospital. He arrested, and someone forgot to read the no code status. I had another patient this happened to, similar circumstances. He was a COPD patient. His lung doctor overrode the code status and revived him. He was a friend, a neighbor to my family, and he asked me why he was brought back. He was miserable. He was always gasping for breath. So yes, there is some information that needs to be pulled from encounter to encounter. What about diagnoses such as HIV? This is important for caregivers to know, but shouldn't we be using precautions that would keep us safe regardless if someone was HIV positive or if someone tested positive for TB? Probably. But here's another scenario. There are some areas that are not as clear-cut. What about a diagnosis related to behavioral health or mental illness? Should these be pulled from encounter to encounter? An argument can be made that patients with previous behavioral health diagnoses are treated differently. These are all facility decisions. The facility needs to document a policy for this type of circumstance. Plus, there can be lawsuits if patient care can be proven to be compromised because of a diagnosis. So these are all things to consider. So let's talk about some actual displays. Every EHR has to identify a patient somehow. The three major EHRs, Meditech, Cerner, and Epic, use a patient display bar that appears on every page of information that is shown for the patient. For simplicity, I'm just going to refer to this as the banner or the banner bar because it's a banner that displays important information for the patient. The facility that uses the EHR helps to sign the information that is displayed in the banner. Generally, the banner will display the patient's name, age, gender, date of birth, location and room assignment, the medical record number, the encounter number. But additional information that the facility might put on the banner bar could be things like allergies, the fact that they're recorded, not the actual allergies, the code status, if there are existing medical records available from outside facilities, and maybe alerts such as COVID-19 or MRSA or some kind of a risk like a violence risk or something like that. But be aware of overloading the banner or the banner bar because this can bring a lack of importance to it. So sometimes simple is good. So let's talk about dashboards. And I've kept this screen simple on purpose. Dashboards have become a new and frequently used tool that can provide important information. First for the nurse, and I love dashboards. They're a quick look. A dashboard can provide a quick overview of patient information. When the nurse gets a patient assignment and enters all the patients, the dashboard is going to provide a quick view of things like the patient code status, vital signs, medications, treatments, and anything that might be essential to the patient. This is like an electronic report sheet. This does not replace a verbal handoff. How about at the charge nurse level? The dashboard provides an overview of the floor by all patients. So this might be a screen that the charge nurse sits and looks at as he or she is working. And this is probably going to give a level of maybe vital signs are not appropriate, but it would be indicators such as isolation, code status, any type of alerts or warning scores, whether telemetry is in use, open beds, pending discharges, things like that. How about for the supervisor? In a clinical setting, the supervisor would be able to view open beds, potential discharges, surgeries, potential ED admissions, potential transfers. Now step back to an administrative level dashboard. In the ED, the role of the dashboard could show the number of patients seen, the average wait time, the number brought in by ambulance, the number that come in by personal vehicle, the number of walk-ins, the number seen for trauma, a cumulative total of patients in 24 hours, a cumulative total for the month, and that would increase as the days advance, cumulative total by year, and so on. This type of dashboard can be tied into staffing reports and financial reports. Individual dashboards can be developed for each unit, but typically they're divided by types of units. So a dashboard for critical care areas. If there are multiple critical cares, they would all be tied into this one dashboard. Medical surgical areas, behavioral health areas. Now step back one more level and think about a dashboard for the entire facility that provides an up-to-date census at the time you're viewing the dashboard. This dashboard I could look at and I can tell you how many patients are on the second floor in the ED, on the fifth floor in surgery. From this, I know what staffing needs I need, how many many times administrators will call in directly to their floor and look at the dashboards, and by looking at the dashboards and send home staff because patients have been discharged and the units appear to be overstaffed. But this can sometimes be short-sighted because they're not always looking at the entire census. Additional dashboards can be utilized for areas such as respiratory care, radiology, surgery, you name it, it can be built. The options are unlimited. Dashboards have become an advantageous tool. I love the dashboards.
Dr. Rose, sorry for interruption. I sincerely ask you if we could have a break for 10 minutes.
Sure.
Thank you. We'll be back after 10 minutes. Hello everybody, thanks for following us. Before continuing of the valuable lecture of Dr. Melody Rose, we have Dr. Alireza Nikbakht Nasrabadi, full professor and dean of the School of Nursing and Midwifery at Tehran University of Medical Sciences. Hello, Dr. Nikbakht, how are you? You're at your service.
Hello, Ms. Mohammadi. Hello, dear professors and participants of the second short-term online training nursing informatic course. Do you have my voice?
Yes, thank you.
As the Dean of the School of Nursing and Midwifery in Tehran University of Medical Science, I'm so happy to be present in your enthusiastic and scientific community, and I'm proud that in this corona pandemic, while many of the world's usual activities, including academic activities, have not yet returned to their normal natural routine, your interest in education and learning have gathered such a valuable team of nurses, outstanding professors, and health professionals from different countries to participate in the second high-quality nursing informatic international online short courses. As you know, Tehran School of Nursing and Midwifery, with more than 80 years of history in the field of nursing education, is the first ranked school in Iran and is also a leading school in the region. Therefore, during corona crisis and its negative effect on international activities and cooperation, we decided to start a new topic in nursing education, which has been neglected in the country and in the region to prevent the recession of nursing education. The weakness and shortcoming in providing clinical, educational, and counseling services in the corona period, which were mainly due to relying on routine in the outdated methods and unwillingness to deal with new problems with new approaches, showed us that to deal with the health problems in larger scale, we need to use modern science and take advantages of solutions that expand the scope of our information acquisition and service delivery beyond current limitation, and provide the possibility of networking, information exchange, big data analysis, online education service, and telenursing, telemedicine. In other words, Corona, with its large and uncontrollable dimensions, showed that neglecting to return to the web-based, internet-based, computer-based service can lead to the collapse of healthcare system. In order to meet this need, Dr. Asiya Darwish, with more than 15 years of experiences in scientific activities in the field of nursing informatics, and the member of the Department of Medical Surgical Nursing of the school, with the full support of Vice Team for International Affairs, designed two short international online courses on informatic and information management system, on information system and information management system in nursing, with sincere cooperation of Dr. Tanya Azadi, a hard working of international campus of TUMS, and with the technical support of Appraise to Raise group at TUMS. Thanks to invaluable assistance and cooperation and teaching of the world outstanding professors who are pioneers in this field and have valuable publications, this course were held with excellent quality. Here, I will name the professors and express my gratitude. Professor Dr. Tony Hepta, professor of nursing, who is also present in today's meeting, I think, from Chamberlain University, from USA, Professor Cyprus, and from College of Nursing of Walden University from USA, and Dr. Melody Rose with her today's valuable informatics lecture. She's Doctor of Nursing Practice in Nursing Informatics, Master Degree in Nursing Informatics, and Adjunct Professor of Franklin University from USA. And Dr. Wilson, the Doctor of Nursing Science and Associate Professor of the University of Alabama from USA, and also Dr. Tanya Azadi, lecturer and health informaticist and health informatics scientist of TUMS, Dr. Asiya Darwish, outstanding lecturer of our School of Nursing and Midwifery, as the biggest and oldest school among more than 200 schools in the country. And also here I would like to thank the executive team, director of the program, Dr. Khatr Seilani, Vice Dean for International Affairs, and other cooperators, Dr. Nasrin Rasulzadeh, Dr. Fatemeh Bahram Nejad, and also executive team, TUMS students, Behnam Ravande, Master Degree Nursing student, Nafise Ismaili, Master Degree Nursing student in the, I think, Beirut American University of Beirut, I think, and Mr. Mohammadian, Bachelor Degree student, and the executive support of International Affairs Praise to Raise team, Ms. Sadeghi and Dr. Muqaddam and other colleagues there. These courses were excellent and successful, as evidenced by the feedback we received from you, our active, motivated, and interested audiences. And if it were not for your energetic feedbacks, the second course might not have taken place so quickly. So in addition to appreciation the efforts of our colleagues, students, technician teams, in international professors, I would like to thank you, dear audiences, for your participation and positive feedback and excellent reception, for providing us with the energy and motivation to continue holding this training course. Wishing you the finest of health and success in order to expanding the human service of the nursing profession to the whole community and approaching the ideal of justice in health and universal health coverage by relying on new approaches such as nursing informatics. Wish you all the best. Thank you.
Thank you so much, dear Professor Nikbert. I think we should welcome again Dr. Rose to continue her invaluable lecture. Thank you.
Okay, so let us continue with clinical decision support. Can someone acknowledge that you can see my computer screen again?
Yes, it's clear.
Okay, very good. So we'll continue with a little bit about clinical decision support. What does this mean? I think the definition of clinical decision support has changed as and continues to change as electronic systems evolve. There was a time when the EHR was in its infancy, that being able to pull data such as the information that is displayed in the banner bar was considered a great accomplishment and also considered clinical decision support. Possibly it could have been considered clinical decision support if the clinician based a decision on something displayed in the banner bar. We learned that trending data is such as blood pressures and showing them to a clinician could be valuable. We also found that when the clinician performs something like a capillary blood glucose test at the bedside, The value can be automatically transmitted to the lab at the same time the clinician sees it, and the result through a wireless network. This makes it unnecessary for the clinician to actually document the result. The result is automatically documented, and the provider can see the result as soon as it's posted. Building on this, if the values are outside of a predetermined normal, alerts can be triggered to send messages, notifications, in a variety of ways. Automated notifications can be in the forms of emails, text messages, printed messages, and be general or specific depending on the form. So, for example, if a text message is not considered secure, the text message can simply indicate that the provider should go check labs, not identifying a specific patient. Other areas that clinical decision support can be introduced include pharmacy. Pharmacy clinical decision support identifies things like patient allergies with a drug and drug-drug interactions. Many times, the different levels of pharmacy clinical decision support are not built because of the intense amount of maintenance that is required. Examples of pharmacy clinical decision support might be different levels of alerts for drugs based on the type of provider. So an example of this might be a provider that specializes in nephrology. They may not need to see the same alerts that a hospitalist would see for drugs that are nephrotoxic. If a drug has multiple uses, different alerts could be based on the usage and the dosage and the specialty of the provider ordering the drug. But these alerts are not typically built into the system because drugs and alerts change rapidly, liability is high, and if alerts are not placed, and they should be. So there is still a dependency on pharmacists to communicate with providers for specific instructions rather than utilizing clinical decision support in pharmacy systems. Other areas of clinical decision support are in value checking multiple quality indicator lists before a patient is discharged. So let me give you an example of this. And again, this is tied to a financial reimbursement. If payment for a non-STEMI elevated myocardial infarct is tied to 7 different elements, those elements would be if the patient received aspirin on arrival, evaluation of the left ventricular ejection fraction, aspirin prescribed at discharge, beta blocker prescribed at discharge, and ACE, ARB, or ARNI for VLSD is prescribed at discharge. High-intensity statin is prescribed at discharge for patients less than or equal to 75 years old, and a P2Y12 inhibitor is prescribed at discharge. This list of milestones can be set up as prompts for the providers and the in the EHR as quality indicators. Now, these milestones are reached. As they're reached, they're checked off in the computer, so that those that are left unchecked are addressed by the provider as the patient at the time of discharge. This type of quality listing can be done for providers, case managers, and any type of role that encounters financial impact in patient services. The list is noted based on diagnosis for all contributing caregivers to see during the patient's stay. Now, one thing I want to be very clear about is alert fatigue. That's why I put this slide in red. I want to caution the use of alerts. When providers, nurses, even everyday people are repeatedly given alerts, the alerts become routine and ignored. Think about your everyday life and the number of clicks you have to make because an alert has been put in place. You simply want to file a document or send a message and you get an alert that asks you, are you sure you want to do this? Well, the same thing happens to providers if too many alerts are put in front of them. Plus, providers have the added feature of constant interruptions from phones, pagers, and people asking questions while they try to document. So please be mindful of the amount of alerts providers and nurses see. So let's talk about remote systems in nursing care. Let me preface, in a critical care setting, nurse-patient ratio is usually 1-to-1 or 1-to-2. That patient is hardwired to the monitor and the nurse is typically close, if not at the bedside. But in an acute care setting, the staffing is much different. Depending on the type of unit, the patient might have a team of caregivers that consists of a patient care tech, a registered nurse, a charge nurse, a provider, a case manager, social worker, so a variety of team members. That patient care tech might be providing most of the patient care, while the RN comes in and assesses. The RN and the charge nurse might actually administer medications. If the patient is wearing a cardiac telemetry monitor, that patient is monitored remotely from a different location that is sometimes in a different city. This is a change that's being made possible by closed-circuit telephonic systems dedicated to the hospital. The patient care tech, the RN, the charge nurse, all carry phones that can be reached by a remote monitor tech at any time if something goes wrong and the patient needs to be checked. Now, there is a plan B in case some type of a disaster or a natural disaster happens. Plan B is a backup of a central monitoring station within the facility that can be manned if necessary. And just as a reminder, I just want to mention that on Christmas Day, Nashville had a bombing in the downtown area that wiped out our communication systems for about 5 days. This was unexpected, but with this type of system, with a centralized monitor station, it would have taken that out. So we would have had to bend on Plan B. So you always have to have a backup plan. Now, another application of remote systems in smaller or rural facilities that do not staff a 24-hour pharmacist, a centralized pharmacy is used to review and dispense medications for new patients. This can be done through the use of automated dispensing machines at the local facility. So the pharmacist is off-site, miles away. They review orders, okay them, and then trigger the on-site dispensing machines for the nurse to get the medications. One drawback is that not all dispensing machines have all the medications, so the nurse may end up going to several different machines if there is a long list of medications or the medications needed are not common. I will also remind you, for a number of years, small and rural hospitals have had difficulty staffing critical care providers, and in some cases have gone to after-hour remote providers. This has worked well. The hospitals that I have had experience with using remote providers have all indicated the remote providers were always available, more available, in fact, than on-site providers, and always had great outcomes with them. This doesn't mean that the patient had great outcomes, just that the provider care was great. Now, also, remote radiology has been used for years too, successfully reading radiology exams and procedures. There are always going to be areas that a provider will need to be present and hands-on. But think about this. In today's world, many of our providers are aging out and there are not providers to take their place. Who will pick up those roles? Nurses, in some capacity, will fill those roles. In a code situation, nurses are already running most codes based on American Heart Association protocols. In a critical care setting, the nurse does the work if the doctor can Zoom, and by Zoom I mean remote in, and give direction. The nurse can do most things. Nurses already deliver babies when a baby just won't wait. Nursing is filling more and more of the provider roles. Technology can provide a portal to Zoom a provider into necessary situations so that the hands-on situations can have an in-person provider. So let's go back to COVID-19 for a minute. The last time I lectured, COVID-19 still seemed to have a grip on the world, and now things have gotten a little bit better. At least they have in the United States. I hope they have where you are. I have to admit, I've come to like working clinical informatics remotely. There has not been many things I can't do at home that I would do from my office at the facility. The group I work with was sent home last year on this March 17th, and we were told we were non-essential. So let's go over some of the things that we actually did when COVID struck. We designed the documentation screens for initial COVID questions. These had to be built and tested in 2 different environments because we always build in a non-production environment and then we build in a live environment. The documentation had to be incorporated into reports and dashboards. Daily, we run reports for infection control for COVID contact tracing, both by patient and employees. We had to build new locations, units, and beds in the Cerner Test Hospital, and then repeat this in the Live Hospital. At my location, we had to build 26 different units. This meant converting, in some cases, hallways, waiting rooms, libraries, doctor lounges, ambulance bays. Wherever we needed the room, that's what we changed into an active location. I also helped do this for all of the Nashville hospitals, not just mine. The location, units, and beds had to be set up for the right payment types, patient types, and be able to provide transmittable information for statistical reporting. When the surges passed, or when they got a little bit less, we shut down most of those locations so that they were not accidentally used. When the COVID surged one more time, we had to reopen some of these units and then shut them back down again. We also provided a new style of communication for families that were no longer allowed to come to with their loved ones to the hospital. Our hospitals wouldn't allow visitors. You dropped your family member off at the door and had to leave or wait in the parking lot. There were two exceptions, birth and death. A father could come in for a family birth or for the birth of their child, and a family member could come in for a death. In August, COVID seemed to settle down, so our projects came back online. But then we surged again, and at that point, we were doing both COVID and projects, so we got very busy. When the COVID vaccine came out, we had to build COVID vaccine clinic locations. We had to build administration screen processes, and these were a little bit different for us because these were all outpatient oriented. Then we had to provide reportable statistics. Now, as a sidebar here, some of us participated in local citywide vaccination events as volunteers, and I actually got to shoot people. I became a car side nurse for a day. Through all of this, even though we were deemed non-essential employees and we were working from home, we were actually still going into the facility because we still had to train new providers. We had to participate when new floors were opened. We still updated software changes and upgrades. I'm not sure anyone except our bosses realized that we were really working 60 plus hours remotely every weekend, taking call and working weekends. And I think we were all looking forward to going back to the facility and kind of cutting back to that 40-hour-a-week work week. So clinical informatics is a role that I would define as truly at the bedside. This is a role that works with providers, nurses, therapists, any type of caregiver that is working with the patient. But this is not all clinical informatics does. We are also the mouthpiece of what needs to be done. We see the problems and the potentials at the bedside and can communicate these to the right place for improvements. There are a group of informaticists that learn how to program or manipulate the system to perform the way clinicians need. This role can be called many different things. It's not a true programming level, but oftentimes it's referred to as programming role. These are the screen designers, rule builders, attribute appliers, depending on the system that you're working within. This layer of support is usually made up of nurses or people that have a great understanding of clinical work and know what is needed. Research is another area that is becoming increasingly important in informatics. We have gathered data for many years, and now we have to start aggregating that data in a meaningful way. We are also on the verge of learning how to make the vendor data interactive, possibly through data repositories, so we can really pull a trend across all platforms. Education is always a great area for informatics, since this area is not taught in the pre-licensure level, but suddenly becomes a specialty area at the master's level. Incorporation of informatics is necessary from the first day of nursing school. We need teachers of informatics. Leadership in informatics is also necessary, a force that is being recognized. The role of Chief Nursing Informatics Officer, CNIO, has been recognized as an executive role and necessary as an executive office. These are just a few of the roles available to nursing informatics. There are many more, and more roles evolve daily. So what questions do you have for me?
Dear Dr. Rose, thank you so much for your invaluable lecture. I think you have part 2 also, yes?
I do. I have 2 clinical
Yes,
decision
okay.
support projects I'd like to present. So
Okay.
I'm gonna,
I think I already wrote in the chat box. If they have any question, can write in the chat box. But I think if you agree, you continue and at the end, they can speak and write down their question.
all right, let me
Do
pull
you
that.
agree?
Yeah, that's fine. Let me see if I can pull that PowerPoint and get to it.
Thank you so much. Then after that, we can have question and answer actively. Dear participants, please do participate in the question and answer at the last of this session. Today is the 4th day and the last session of this short course. We will have the other short courses also in future. So be in contact with us and we will inform you about those.
Okay, can you see my screen?
Yes, it's clear. Thank you.
Okay. So I want to take some time and provide a couple of projects that I have or am working on in the world of clinical decision support. Now, the typical abbreviation for clinical decision support is CDS, but there are also other things in informatics that use this abbreviation. So make sure you define CDS when you use this abbreviation. Clinical decision support is one of the coolest things that has come out of informatics, but you have to remember that these are simply tools and need to need the interpretations, clinical judgment, bedside intuition, and nursing wisdom to make them valuable. So the objectives that we're going to go over are we're going to identify everyday events that can be triggers for clinical decision support tools, identify when specific questions need to be built to facility clinical decision support tools, recognize the need to generalize research from facility to facility, recognize a complete view of the project from start to finish, and recognize the value of projects at a national level. So let's start with eMuse. This clinical decision support tool is real life and can be readily applied to the patient. Multiple years ago, I was approached by one of my friends about a study she had read that highlighted something called modified early warning score. That was shortened to MUSE. Now, I had worked with this friend several different areas, places, and roles of nursing over the years, so I knew her well. And the timing was excellent on this encounter as we sat in the cafeteria that day and she described MUSE to me. Her name is Dr. Leanne Hanna. A quick overview of MUSE is that a patient that codes or suffers a catastrophic change in condition usually shows subtle signs and symptoms up to 8 hours in advance. If we look at the right trigger points, we might be able to catch these patients before they have that catastrophic event and reverse their course. Studies were showing multiple trigger points, but there were 5 that stood out: systolic blood pressure, pulse rate, respiratory rate, temperature, and level of consciousness. As Dr. Hanna told me about this study, I recognized that these were all data points that we collected in nursing documentation with one exception. The exception was the way we collected level of consciousness. At the time of the original conversation, we collected level of consciousness data as alert, confused, not alert. So we made a modification and educated the staff to the necessary collectible data trigger points. We changed level of consciousness data to the AVPU scale: alert, arousable to voice, arousable to pain, unarousable, and we were on our way. Now, timing is everything. I need to mention that at the same time we were working to automate Muse, the hospital was also developing and engaging a rapid response team. So there was a big awareness on saving the patient before they needed to be saved. The initial implementation for this was a large hospital, 650 beds. The hospital was fully behind this project and provided resources for it. All staff were educated and the project was a success. So let's talk about the eMuse criteria. And I can officially call it eMuse. Once it was electronic, we simply added the small letter E in front of Muse for eMuse. So eMuse is a point system that assigns a score to every data trigger. There is a normal score for every value, but understand that some patients will be outside of that normal all of the time. For these patients, we know they are typically slightly out of normal. So think of your COPD patient that might be breathing a little harder, or a pacemaker patient that has a slower heart rate, and that's okay because eMuse is a tool. We always treat the patient based on the true clinical picture. On baseline assessment, the patient receives an eMuse score. We like the score of 0. If the patient meets all normal criteria in the 5 data trigger point areas, they receive a score of 0. After the patient has a baseline score, we look for a change of score in 2 ways. The first way is a score of 5. The second way is an increase of score by 2 points. Now, if the patient starts out with a score of 5, there's a problem, and they're probably headed for a critical care area. So let me pause here for a minute and define the audience for eMuse. eMuse it can be used anywhere, but it's most efficiently and effectively used in non-critical care adult situations. Think of areas that the nurse might have a divided attention, 4 or more patients, frequency of admission and discharges. The nurse may be tied up with frequent vital sign patients, so maybe they've just gotten a post-surgical patient back that they're doing frequent vital signs on, or giving blood. There might be a mixed level of staffing used. Also consider new nurses that may not have that critical level of judgment developed, or that nurse's second sense, you know, when you walk into the room and you just know something isn't quite right. So another way of how did we go from Muse to eMuse, electronic modified early warning score. Part of that was simply timing, as I described earlier. The primary setting for this in the adult non-critical care unit, when I first started my nursing career, all vital signs were collected manually and recorded on a piece of paper. But at the time eMuse was being developed, the acute care floors were also transitioning to an automated monitoring system that interfaced with the electronic health record. So instead of manually putting that blood pressure cuff on and using your stethoscope, they were putting the blood pressure cuff on, and a machine was taking the blood pressure and all the vital signs and linking up into the EHR. In this case, the EHR was Meditech. Vital signs documented included the 5 exact data triggers points of eMuse: systolic blood pressure, pulse, respiratory temperature, and level of consciousness. And we did make that modification for level of consciousness. We also trained unlicensed caregivers to assess the level of consciousness if their job description asked them to collect vital signs. Anytime a complete set of vital signs was documented, the Meditech system was programmed to apply the eMuse criteria and display the score. So what you're seeing now is the criteria and the point scale system. What you're looking at now is an actual Meditech eMuse screen. And let me just give you a brief explanation. I don't pretend to be a programmer. At the time we developed eMuse, I could do a little bit of background rule application to make this work, but not nearly enough, so I asked for help. There are many people trained in this type of thing that work all angles of the if-then and what-if scenarios that go along with programming computers. Programmers come back with many questions, and that's okay because they usually ask things that I don't think of, and that's part of teamwork. An example of this is I was asked, do you want the score to show on the screen when the vital signs are documented? Well, I hadn't thought of that, but once it was demonstrated to me, I liked it, so we went with it. They also showed me what happened if a complete set of vital signs was not documented. Basically, nothing happened. So next, where do you want the information to display and how? Well, I had always pictured a nice paper report. Not really, not really. We're going electronic here, so no paper. We actually had the output reported in several ways. First, we created a destination for EMU score in the vital signs section. As the values of the vital signs trend with the numeral score of EMUs, we could also watch that trend. The current value was also sent to the dashboards that displayed for various levels of employees to see. We did trigger a report to the unit location the patient was assigned to when they met criteria. And remember, that criteria was a score increase by 2 or a score of 5. That same criteria also triggered a page that was sent to the assigned nurse, the charge nurse, and the nursing supervisor. And many times I was the nursing supervisor. In a larger hospital, that same alert would be sent to the rapid response team, and they would see the patient automatically, hoping to identify whatever was triggering the EMU score. Now, retrospectively, not all triggered alerts are relevant, but remember, we're looking for a trend and then watching that trend. So taking a project and making a project. One important part of nursing informatics, nursing research, nursing at the doctoral level is the ability to recognize something good when something good is not working and how to fix this. I was working at a smaller hospital as a PRN nursing supervisor. And if you remember from my introduction, I mentioned that I thought it was important to work clinically, PRN, along with my informatics day job. I was also in school at this time working on my doctorate, and I admit I was tired a lot. I recognized that the small hospital I was working PRN was not using EMUs as it should be used, and I started asking the staff about what they thought EMUs was. After about 20 interviews, all of the responses were, "What is EMUs?" No one knew what EMUs was. They had not been trained on the tool. When EMUs was installed and implemented, it was done at the same time a new portable vital sign monitoring system called Capsule was implemented. The staff was trained on Capsule, but not on EMUs. So for my small PRN hospital, I used the reinitiation of EMUs as my capstone project for my DMP. The Capsule EMU system had been put in a year before, but because the staff had never been trained on EMUs, no one knew what it could do or how it could be used. I designed a very quick training session, 4 minutes or less, that could be done one-on-one or in small groups. I trained 90% of the nurses, nursing staff, and many of the respiratory care staff on all shifts, all including the weekends. I also included as many of the unit secretaries as I could get. The training was easy, and I left many training packets for those that I did not get to. Some of the key things about training: be consistent with the training, make it easy to understand, and build in a repeat back process to evaluate the learning. In this case, I also included an important step of how to engage rapid response team if needed. This was not part of EMUs, but still part of taking care of the patient. The small hospital does not have a dedicated rapid response team. It utilizes a call team that responds to an overhead page. So engaging rapid response team was an important step. We studied trends before we started EMUs, and then we followed them after training. We got great results back. We saw a reduction in code blue events in the acute care areas, an increase in rapid response team calls, and after 3 months of collecting data, only one patient died on the acute care floor as a result of a code. Ironically, the patient that died had a pacemaker, so one of the data trigger points had an external bias that probably altered the true EMU score. Now here's an interesting side story that didn't come out until about 6 months later. and I noticed a lack of rapid response team and code blue calls on the third floor. So sometimes it takes a while to notice when something isn't happening. Remember, I continued to work PR in this hospital, so every weekend as a nursing supervisor. I worked with the same staff, and I finally took the charge nurse, Mary Ann, on the third floor aside one day, and I asked her why and how the third floor had reduced the number of rapid response and code blue calls. As it turns out, Mary Ann had been watching the EMU's scores, and this goes back to the dashboard display for the charge nurse, and she was personally running interventions on patients when they started to show changes. So what a great nurse Mary Ann is, and what a great clinical decision support tool. So now, if eMuse is something that you are interested in, I will gladly give you anything that I have on this topic. Now remember, my tools are a bit old, but the application is solid. eMuse has also evolved a bit and has been used in identifying sepsis. It is a great tool. So the next clinical decision support tool I want to highlight revolves around violence in the workplace. So this takes us off in a little bit of a different direction. Stepping back a minute, remember the roles of our bedside caregivers. Usually it's the RNs that are educated to associates, bachelors, and some master's degree that we count on for identifying problems at the bedside. We also pay attention to nursing technicians, LPNs, LVNs, respiratory therapists, lab techs, anyone that's giving direct bedside care that can identify a problem. So recent development in the United States has been identified as violence towards these healthcare staff. This has become an increasing trend. From my personal recent experience, I can think of 3 very real experiences, all happening to the levels of staff just identified above. The first one, a very young and limited experience night shift nurse went into a patient room to do her initial assessment. She either shut the door or the door closed on its own, we don't really know. As she was bending over the male patient, he grabbed her and started punching her. Because the door was closed, it was night shift, limited staff, no one could hear her cries for help. She eventually escaped the room, but she was traumatized by the event. The next event happened when I was teaching at an undergraduate level. A student arrived for my evening class, and he arrived late. It was a scheduled exam night, and his late arrival was completely out of character for him. I was about to tell him that he could not sit for the exam because that's the school policy, when he started explaining, and he was rather out of breath. He said that he had been at work and a man had entered the ED, and I knew this student worked as a tech in the nearby ED. He said the man had a gun and the ED had been locked down, and this is why he was late. I let him take the exam, and he did well. And just as a quick follow-up after the exam, I let him talk through the experience with the class as a de-escalation tool. He seemed to need it, and I felt the class needed to hear about the real experience. The last example I bring to you is from my little PRN hospital that we just installed eMuse in. And I was working a Saturday shift as a nursing supervisor and received a stat call to the ED. 2 of the nurses had just been sexually assaulted by a patient. The acts were caught on video. The patient had come into the ED with a diagnosis of something very minor, not feeling right, being off of his meds. Nobody knew he was referring to psych meds. When asked, what meds do you take, he handed the nurse a small plastic bag with many pills mixed together. The nurse was standing at the nurse's station trying to identify each pill when the patient walked out of his room, came up behind her, grabbed her from behind, and tried to perform a sexual act. There were many people at the nurse's station that witnessed this. He then walked down the hall into the triage area, and at this point, people were realizing what had just happened and were starting to react. He grabbed another nurse, turned her to face him, backed her up against the triage desk, and did the same thing. As this happened, the charge nurse and several other people came into the room and moved the patient away from the triage nurse and put him back into the patient room and assigned a security guard. But in the time frame of 30 seconds, this man had sexually assaulted 2 nurses without warning. Now, I have other examples, and I suspect if you think about it, you might be able to recall examples yourself. This is a problem. but nurses really do not ask or document any type of data about violence that might be directed at caregivers. We ask patients if they have been in situations of domestic violence or fear for their own safety. But what about our safety? Is there a way we could build a clinical decision support tool that might indicate patients could be at risk for violence? If so, what would it look like and how would we spread the word to our colleagues? Looking through the literature, I did not find any research that had been done in an acute care setting. I did find research that had been done in the behavioral health setting. And now I need to stop here and give credit where credit is due. I was asked to come into a project that was in full flight in the paper world. The nursing team at my current hospital had done the work, found answers, built a great tool, piloted on paper, and wanted to make this into an electronic, automated clinical decision support tool. They had done the hard part when they asked me to come in, and I was simply looking at research trying to figure out how they made the leap from behavioral health to acute care. And that's what it was, a leap. Sometimes you just don't know, so you try. They looked at articles. They found a violence risk assessment scale that was used in behavioral health, applied it or generalized it to acute care, and piloted it in a unit. The work is based on Brosette Violence Assessment Scale and is available for anyone to read. The CNO did ask permission from the publisher of the Brosette scale before using it. The nurses built a paper tool and asked the staff to assess the patients for confusion, irritability, boisterousness, verbal threats, physical threats, and attacking objects. A point scale was assigned for each assessment data point. The outcome was no risk threat, low risk threat, and high risk threat would be identified at certain levels. So let's look at the assessment tool first. The patient is scored on 0 for no, 1 for yes point scale. They're scored on admission. If the patient is confused, irritable, boisterous, verbally threatening, physically threatening, or attacking objects. If the patient scores 2 or higher, they are identified as being at risk for potential violence. Identification for low and high risk should be a facility decision. Now here's a disclaimer for you. Research has to be generalized appropriately to make sure it fits. Definitions for all 6 of these assessment criteria are displayed on the paper if it's the pilot, and on the electronic screen if it's in the system already. Making the generalizations here, let me use me as an example. I'm probably always going to score a 1 for irritability when I have to go to the hospital. I don't like hospitals. Quite possibly I'll score a 1 for attacking objects too. I have a background in martial arts, and one of my stress outlets are simply doing karate forms, which could be interpreted as attacking objects. It is part of me. It's my culture. So what am I saying? What I'm saying is this: be reasonable with the interpretation and the generalizations and make sure they fit. Not all research will work in all settings. Moving on, other things that can be built into the electronic screens include interventions for the staff. Things like turning the lights off, keeping noise levels down, keep visitors out, or maybe keeping that special person in that calms a person, things like this. Brainstorming. These are questions that nurses did not previously document. There were easy enough to build. We know how to build, right? I mean, I talked about that in the last lecture. But then we had to consider a couple of things. What if a patient was not the potential source of violence, but maybe a family member? The paper questionnaire did not address this, but once the project team got a little bit bigger, the ideas expanded and the areas applied had different circumstances, so we had more to consider. The family member issue came from the mother-baby area, where there are sometimes issues with dads that are violent, and that actually just happened this week at my hospital. We had a dad that threatened to blow the place up, and he was escorted off the property. The original paper pilot did not include this population. This is why It is very important to have all stakeholders involved when building and evolving the process. So as the process runs down the road, think about these things. Where will the patient be assessed? Will this be done at the first point of contact or in the more comprehensive admission process? When will they be reassessed? If they do not meet violence criteria, do they need to be reassessed? If yes, how often? If no, can the caregiver resurrect the violence criteria screen, and how? If yes, how often are they reassessed? Will this be on a shift assessment or a freestanding form? And the questions will go on, and I guarantee you it's going to be different for every hospital. So different teams. If the patient assesses for high risk, how are other caregivers going to be notified of this? Are there electronic warnings that can be put in place? At my place of business, we wanted to put an alert in place the first time the caregiver opens the chart every 24 hours. Now think alert fatigue. We didn't want to see it every time. Should this be every time the chart? No, we didn't want it, but it could be. Should there be an indicator on the banner bar? I wanted that indicator there. If so, should the indicator stay on through the entire admission? If the patient is no longer meets the criteria, should it stay there? Think about the patient that's going through alcohol withdrawals. They're violent for the first 3 days and then they're probably okay. Should this indicator follow the patient from visit to visit? These are all questions and things that have to be worked through at the facility level, and then policies and procedures written. Paper signing is definitely okay in this situation. Some caregivers will not open the electronic chart. If a patient has been identified as a risk for violence criteria, they should know this and be aware of it, and know what actions are going to be taken. Think about a sign on the door to identify and warn. General signs can be placed throughout the facility just talking about the program in general. Programs like this need to be tailored to the culture of the society and the laws that are in place. The United States has many diverse cultures and laws between states. These have to be considered when programs are implemented. This is sometimes a hard concept to make people understand when working in a national program. Reporting at the time and for statistical analysis later needs to be considered. Alerts should go out at the time a patient receives a violence criteria score. This should go to the nursing supervisor, the attending physician, security at a minimum. My place of business wanted this to be recorded to a tracking report, which is different than the dashboard that was reviewed daily by administration. The violence criteria status should also be recorded on any type of real-time dashboard that is viewed for current facility use. Policies need to be written that support this process from beginning to end. Please be aware of the way documentation is collected so that statistical analysis can be collected. A suggestion would be to design the type of data you are looking for as you design the documentation screens. If you want to know how many patients became violent, this data will need to be collected. What type of violence was demonstrated? This needs to be collected. We chose not to collect that data. Now, you might be able to sense a little bit of disappointment on my part because my facility was stopped in the process of implementing this. And I admit I am disappointed, probably more for my CNO than for me. I thought the nurses involved in this project did a great job researching and generalizing the information, designing the tool, running the pilot. My role was minor here, but we were stopped about 3 months into the project because there was a national violence project that was supposed to be in place by January 1. So far, that project is not up. It's close, but it's not up. Now, the national project is not as robust as ours. It does not include a banner bar, reporting, or orders, but it will. It goes up in stages. Sometimes working for a corporation, you have to step back and see a bigger picture. The national project is on a slower timeline, but will incorporate all hospitals, not just one. Eventually all, or at least many of the components that we had designed will be in place and be reportable. So imagine the statistical information that can be gained from many facilities rather than just one. So there are some advantages to the bigger picture. So the information I've just presented, for a workplace violence assessment is available to you, and I will give you anything that I have. If you are interested, you can also simply Google a few terms such as BROSET, workplace violence, behavioral health violence, and just start searching. This is how research begins. What questions do you have for me?
Thank you, Dr. Rose. I really enjoyed. I sent some questions to your email, and I ask audiences, please be active audience. And now I think this is a good opportunity, having Dr. Rose as an outstanding lecturer and with a great background on systems in nursing and nursing informatics. And so please ask your questions. And if you have any question, you can raise your hand and speak also.
Hello.
Hello.
Hello. Yeah, I'm Yakubu, joining all the way from Ghana. I wanted to have this discussion with you. For instance, in a hospital where we have the hospital management system, that if a patient, for instance, is admitted, say at an acute ward A or acute ward 1, then another staff who works in the same hospital and is at, say, surgical ward 2 is able to have access to the patient medical information. I don't know whether that is a very good practice.
So you're talking about being able to view records in different locations?
Yes. For instance, nurse A working at the surgical ward 2, then nurse B working at medical ward 3, something like that.
Right.
And you both work in the same hospital. Then you are using the hospital management system. Then a patient is admitted to surgical ward 2. Then the nurse at medical ward 2 is able to view the patient records. Is it ethical?
So we finally got to the point where we locked down access based on patient location. So if I was doing direct care with a patient on the 2nd floor, and the patient moved back to critical care, I would not be able to document on that patient at a computer at the 2nd floor. If I wanted to finish my documentation, I would actually have to move to a computer in the critical care area.
Okay.
Because of the exact problem that you're describing.
Yeah.
We did run into those problems.
Yeah, but the point here is that, like, for instance, is it ethical to be able to view, not even to edit or add any other information? Is it ethical to be able to, for instance, if you are not a direct caregiver to the patient, then maybe you sit in a different ward, the fact that you have the patient ID, then you key in the ID, you are able to view the patient's medical records.
So being able to view a patient is based on your role and your need to know. And that's why we audit. So we don't want people to go in and just peek at charts and or view charts, as you say. So no, it's not ethical.
Okay, so it means that in working with such a system like the hospital management system, for instance, if you are nursing the patient at the surgical ward, now the patient has been transferred out to the ICU. You sitting at the surgical ward should not have any access in terms of viewing the patient who has been transferred out to the ICU medical records.
Right. So, but let me give you a different scenario.
Okay.
I'm a busy nurse. I've got 8 patients on my floor. I've just had a patient crash, and I've had to transfer him back to critical care. I still
Okay.
have my 7 patients that I've got to take care of. I don't really have time to go back to a critical care terminal
Yeah.
and document.
Okay.
So we've built in different things. We ended up leaving that location indicator open for 8 hours so the nurse could document in the previous location. But we do follow up with audits. There are ways around it, but we have run into all kinds of ways to fix it, ways to audit it. But you're right, it's not ethical to just continue. And the other thing is, if I'm an ER nurse and I run into this sweet little old lady that came in and I just want to check on her 2 days later, that's not a valid need to know. I can't just go into her chart and say, hey, I'm just checking on you. That's not a valid need to know.
Okay. So what that means is that the systems should be able to should be built in such a way that if you're sitting at any part of the hospital where you do not have direct care with the patient, you shouldn't have access to the medical records of the patient. So I have an example of that where this particular system, any what's the name, nurse sitting at any of those other wards and do not have any direct care with the patient is able to view the patient medical records.
And unless their role dictates it, they should not be able to.
Okay, they should not be able to.
I would think not. That can be dictated by policy at the hospital level, but I would not recommend that.
Okay. Thank you.
Mm-hmm.
Thank you for nice question and a very nice answer. Please, if anyone has question, raise your hand.
Dr. Darvish, I think Dr. Hebda is asking to be unmuted. Is that possible?
Yes.
Oh, well, actually, I think I was not. I must have scrolled over that accidentally. I'm sorry, but I did want to say that occasionally there are legitimate reasons that, for instance, you did not finish your documentation on someone that needed to be transferred to the ICU. So you would still need to be able to do that. So leaving that window open would give the nurse a legitimate access.
Thank you so much. Thank you so much, dear Dr. Hepla. Okay, Melody Anderson, would you please raise your hand?
Oh, hi. I hope you guys can hear me. Yeah.
Okay.
Thank you for your presentation. Thank you for the school sponsoring this. This has been very, very helpful for me. I'm a telehealth coordinator at a VA hospital here in the United States. And one of my community, my performance improvement projects is looking at alert fatigue because I work in a unit where we care for our spinal cord patients. So we get lots and lots, very interprofessional. So lots and lots of tags on notes, but not necessarily as she described that didn't need any action from me. My question to you is, do you have any recommended sources or resources that I could look at that would provide me further guidance as I continue to develop my QI project on alert fatigue? Thank you.
Alert fatigue. Run. So is your VA hospital gone to Cerner yet?
No, not yet.
Oh, okay.
We're in the process. Mm-hmm.
I would, alert fatigue is a big one. We fight that every day. The best advice with alert fatigue is to communicate, almost over communicate with the providers when alerts come out. And that's something that in my daily work, we don't do well. And at times I don't think it's our fault because we use email as a primary source of communication and providers simply don't read email. We're we're still looking for the perfect solution for that. But we tend to put in changes, and they're changes that are great changes. Like, for example, starting on Monday, we're doing an opioid reduction change that will affect all of the order sets. And this will cause some angst, but not everybody has read their email, so they don't know about it. So it's alert fatigue becomes all about communication and why. So my best answer is communicate and limit the number of alerts that are out there. And once you put an alert out, let the providers weigh in and decide, or at least have a voice in whether they think it is an appropriate alert.
Okay. Oh, that's a great idea. Thank you. Because I've been the sender of alerts as well as many times the recipient. Last year, I received over 500 alerts, of which only really 25% was any one particular item that I need to be involved with. And I do have a problem of being assertive as a nurse. You know, I feel like sometimes, especially working with physicians and other clinicians, to be able to communicate without appearing intimidated or being very sheepish, to be able to express that I don't necessarily need to be alerted on all these things. It's nice to know, but not necessarily on a need to know basis.
Right.
So thank you.
Thank you so much. And did you look at your email, Dr. Rose?
Did I? No. Let's see.
I sent you 2 emails.
2. Okay, I see. Dr. Kevin O'Neill says that nursing informatics is a bachelor's program for 15 years. Good job, Dr. O'Neill. I'm very proud of that. That is awesome. I'm very limited in the hospital. Okay. How can we overcome alert fatigue? That was from Janet Salanda. Janet, did the conversation that we just had answer your question? And I think the second question from Sheikh Samala was about alert fatigue as well. So have we discussed alert fatigue well enough? Oh, there's another one. Okay. Oh, how easy can we replicate the evidence-based informatics in nursing in Africa? You know, any of the evidence-based informatics, so the clinical decision support stuff that I just presented all started on paper. You can do any of the evidence-based stuff. You don't have to have a computer system to do that. You can start that on paper. It's cumbersome, but you can hang a piece of paper at the door and you can trend your results at the door and see it. Clinical decision support is more about having a trend at the bedside, or as much about it. So if you can consistently have someone calculate when the nurse goes in and does a set of vital signs and calculate a score, you can do an EMU score and set it at the bedside or see it on the door. It's the same thing with the risks, violence risk score. Any kind of evidence-based practice usually starts as a paper pilot, or can start as a paper pilot. So it's just a process of reading, deciding how you're going to generalize it to your facility. And many times projects start with big hospitals, because who has the money to do this? Usually the resources go to the big hospitals, And that 650 bed hospital that we did the original EMUS project in had the resources to do that, but the little hospital didn't. That's why we were able to generalize down to the small hospital. I used many of their resources. The programming was already built for that. I didn't have the resources to go out and do that. I just pulled them over from that big hospital. It was a sister hospital. So being able to generalize results, borrow, and that's part of what nursing research and evidence-based practice is. You see the research out there. That's why we publish. We want people to use our research. Write to the author. Most research that's out there has the author's email. Send an email. I've gotten emails about the article that I wrote related about EMUs, asking for help, asking if I've done follow-up. Email the author and see how they did it. Ask for help. That's what we're all about.
Hello.
Hello.
Yeah, just another short question. I wanted you to explain for me about what summary report and nurse shift plan report.
Give me a little bit more information.
For instance, we do have on our hospital management system ward summary report, then a nurse shift report. So it's actually a very new system that has been rolled out for the use in this hospital. And when you log in as a nurse in your domain, you have that platform, ward summary report and nursing shift report.
Okay, so you're talking about more like a handoff report or a summary report of what I'm going to do as a nurse when I come on shift?
Something like that.
Okay, so back in the olden days when I was a baby nurse, a brand new nurse, we used to have a Cardex, and we would take report from that Cardex that would give us important information that included the patient's name, the doctor, how long they had been here, all of that demographic information that I was talking about. So
Okay.
when you talk about a report, a handoff report, or any kind of a tool that the nurse is going to do or use from the computer, all of that basic information is going to be going to populate. So that old-fashioned Cardex is gone away, and that automatically gives your nurse a demographic banner bar, basically, with all that information. So you start from there, and your report may generate things like, what are the next medications that you have to give? What are procedures that are going to be done that shift? What kind of treatments?
Okay.
But remember, anything that the computer generates is simply a tool. The nurse still is responsible for treating the patient based on what he or she sees and what the clinical picture is. This is just a tool.
Okay.
The other thing I want to mention here is you're talking about a system. We like that system at the bedside. So if you don't have computer terminals at the bedside, that kind of handicaps the nurse unless he or she has a laptop that rolls around on a cart, or a laptop that's mounted in the room, or a computer that's on wheels that can go in the room. That handicaps them. So we like that tool in the room with them, because that's the clinical decision support at the bedside that helps them.
Okay, thank you.
Uh-huh.
Thank you so much, dear Dr. Melody Rose, and thank you for accepting our invitation and your invaluable lecture. Of course, I will ask you, please send me your references which you talked about,
Okay.
about EMUs and some other things, and we will add the recording session to the website and the slides of Dr. Rose. Thank you, participants, for being very supportive and staying with us. Please, Mr. Mohammadi, can you launch the poll? And after poll, we will have a group photo for the last session of this series of nursing informatics online short course. And thanks all our colleagues, the dean of our faculty and Dr. Ceylani, our vice dean for international affairs. And thank you, Upraise to Raise team. So please, participant, to answer the poll. Thank you.
Thanks to Dr. Melody Rose. It was really fascinating and we really enjoyed it.
You are very welcome.
After the post-test, we'll have a virtual group photo. So in a few minutes, I'll ask you to open up your cameras to take a virtual group photo. If you're concerned about something like hijab or you're wearing, you have the time to consider. %53% of our participants have answered the poll. Thank you. About 60% of our participants have answered the poll. Thank you. We'll wait for others to answer the post-test. About 65% of our participants have answered. Thank you. It's growing up. I'll close the poll in a few seconds. Dear Dr. Darvish, do you want to wait for others to answer the poll? it's 67%.
I think it's okay, and you can share the result and then close the poll.
Now I kindly ask you all open up your cameras to take a virtual group photo at the end of today's meeting. And thank you all for participating in our program and being a part of our program actually. Many thanks to Dr. Melody Rose. We really enjoyed your presentation. It was really great. Please accept our deepest thanks and appreciations.
Thank you.
You're welcome.
We hope to have more opportunity in future in such outstanding lecturer like Dr. Rose. And also we invite the other faculty members who participated in our program, and it's our honor. And we invite you to please, if possible, do collaborate in our future courses and accept one or two session lecture. Thank you.
Okay, the snap is taken, so it's time to say goodbye. But before that, we have to announce that our course was actually is a kind of virtual course that has lecture sessions and offline sessions. So for continuing this course, you have to go to the website and continue the sessions, actually offline sessions. And thanks for your participation and attention. It was really great and kind of you for following us and being with us.
Thank you, all of you. And we enjoyed these sessions with you. Thank you.
Thank you.
Bye-bye.
Bye-bye.
Thank you so much. Goodbye. Thank you.